talk entitled Inpatient Cardiac Arrest in the ERA of COVID-19. Dr. Akwe?
Yes, so let me try to share my screen. Let's see here. All right. Can you see my screen?
Yeah.
I'm not exactly sure how to put this in a presentation mode and still share the screen, but let me try.
Yeah.
Let's see. All right, perfect. All righty. So, yes, my name is Joyce Akwe. I'm the Chief of Hospital Medicine at the Atlanta VA, and I am an associate professor at Emory University. I am a hospitalist by training and in practice, which means I take care of patients with internal medicine problems in the hospital. So my presentation is going to be quotes during COVID-19. And again, this is just managing cardiac arrest in the era of COVID-19. So the objectives of this presentation are for us to learn strategies to reduce exposure to COVID-19 during a code in patients who have COVID-19 or patients who are under investigation for COVID-19. And so some people are more familiar with calling it SARS-CoV-2, but in this presentation, I'm going to call it COVID-19 all the time, patients with COVID-19, and that will cover SARS-CoV-2 patients or patients under investigation for COVID-19. And again, the second objective of this study is for us to learn strategies to reduce cross-contamination during cardiac arrest or codes in patients with COVID-19. And the third objective of this presentation is for us to prioritize oxygenation and ventilation strategies with lower aerosolization risk. So I'm going to start with a case. So let me see if I can bring this down so I can be able to. Oops. Okay, I'm trying to get the images up here so I can be able to look at the case, but if not, I will just go ahead. So we have a patient, Mr. J.D. Smith. He's a 58-year-old man with a history of type 2 diabetes and hypertension who presents to the emergency room for fevers and progressively worsening shortness of breath for the past 24 hours. Mr. Smith was found to have oxygen saturations in the 90s, actually low 90s, and was placed on oxygen by nasal cannula when he arrived in the emergency room. He was diagnosed with COVID-19 and admitted to the COVID unit. Of note is the fact that we have a COVID unit, which is not an intensive care unit, and then we have a COVID unit, which is also an intensive care unit. But he was admitted to the non-intensive care unit, COVID unit. 2 hours after arriving on the floor on the COVID unit, the patient's oxygen requirements started increasing. He now required 4 to 6 liters of oxygen to maintain O2 saturations of 88 to 90%. He was immediately transferred to the intensive care unit where he was placed on a non-rebreather and he went into a cardiac arrest. And this is where our presentation starts. So just some background, I would like us to kind of like touch. We do know that COVID-19 is evolving and has an unpredictable nature. And this has created challenges in how we manage inpatient cardiac arrest in patients who have COVID. And again, when I talk of, I'll call it cardiac arrest, or in some cases you see me call them codes, it's the same. So cardiac arrest or codes. So the existing American Heart Association CPR guidelines did not address any of the challenges which CPR, which will present in patients who have COVID-19 if they have to undergo a CPR. But in April of 2020, the American Heart Association provided some guidance based on expert opinion. So not really much evidence-based guidelines and not much, it was mainly just expert opinion. At that time, that is in 2020, April of 2020, we did not have any good studies. Of course, we couldn't have them because COVID-19 had just started. So, and one of the recommendations from the American Heart Association, which came with this guidance, is that we have to adapt this guidance locally based on the disease burden in the area where we are, and also based on the available resources. So COVID-19, again, as we know, is very highly transmissible, especially during resuscitation. It has very high mortality and morbidity rates. Up to 19% of patients with COVID-19 require hospitalization, and up to 6% of these patients become critically ill. Cardiac arrest is not uncommon in these patients, and we all know that patients who have COVID-19 do have myocardial problems, they have arrhythmias, and some of the medications which are used in treating patients with COVID, which were used originally, such as the azithromycin, will have QT prolongations, can cause QT prolongation, and so exposing the patient at risk of cardiac arrest. And not only, some of the patients with COVID-19 come with GI symptoms, they come with nausea, with vomiting. We place them on medications such as ondansetron, which are medications, again, that will cause can easily cause QT prolongation in patients who already have some alterations in their hearts and can easily lead to cardiac arrest. So we have several reasons, respiratory failure, several reasons for these patients to go into cardiac arrest. But again, if they do have to undergo resuscitation, then we have a very high rate of transmission of COVID-19. So again, during resuscitation, the risk of transmission actually goes up. And this is due to the fact that CPR itself is, this is a process that is aerosol generating. So we do have chest compressions, we have positive pressure ventilations, intubations are very highly, are procedures which highly generate aerosol. And so exposing people rescue us to COVID-19, and again, increasing the transmissibility of COVID-19. Again, providers have to work very closely to each other during resuscitation in patients with resuscitation generally. So if they do have to work very closely together during COVID-19, in patients who have COVID-19, it just makes the transmissibility even much higher. Again, once we have an emergency situation, there are usually lower level of infection control practices. And so again, increasing transmission. We have, one of the things which we know is that, especially when COVID-19 just started, there were worldwide shortages in personal protective equipment. And again, with
I guess she's facing some issue with the net. So we will wait for 2 minutes, otherwise we will raise.
can you hear me?
Yeah.
Oh, I am so sorry. For some reason, I lost contact. Let's see. Okay. I have to share my screen again. All right. Are we there?
Yeah.
Okay. Can you see my screen?
Yeah.
Can you see? All right. Thank you very much. I am so sorry. I don't know what happened, but I'll just take it from there. So again, if a patient comes in with COVID-19 and happens to go into cardiac arrest, you have to have certain goals in mind. The first thing is that you have to prioritize strategies that reduce exposure to COVID-19. You don't want your rescuers, you don't to pick up COVID-19. You don't want someone who is going to save a life because of COVID-19 to give their own life for COVID-19. So it's very important for us to prioritize the strategies. Secondly, you want to prioritize oxygenation and ventilation strategies with lower aerosolization risk. And we're going to talk about those further in this presentation. Thirdly, you want to consider resuscitation appropriateness. And this is a discussion which goes, I would talk a little bit about this, but it's a topic which has been very controversial, and we can discuss this even further. There we go. I'm sorry. So once the patient is admitted for with COVID, and generally, I think this is something we should try to practice with all our patients. We should address advanced care directives and goals of care on admission. So once the patient hits the hospital, we want to make sure that we have very clear goals of care for this patient, and we have advanced directives for this patient. We don't want to be in an emergent situation before having these discussions, maybe with family members. Secondly, you want to monitor for any clinical deterioration to make sure that you minimize the need of emergent intubation. If this patient needs intubation, this is something which has to be done as early as possible. Thirdly, if the patient is at risk of cardiac arrest, you want to proactively move this patient to a negative pressure room in order to minimize exposure to COVID-19. So our first goal, as we said, was to reduce exposure to COVID-19. And how can we do this? We want to make sure that we don our PPEs appropriately before entering the room or the scene of the code or cardiac arrest in patients with COVID-19. We want to limit personnel in the room. We want to clearly define the roles and responsibility of each team member. We want to consider using mechanical CPR devices for adults and adolescents who have a cardiac arrest. And you want to make sure that these meet the height and criteria for the devices meet the patients meet the height and criteria for these devices to be used. And then last but not least, you want to communicate the COVID-19 status to any new provider. And we will go over each of these points. So again, we all know that if a code is disorganized, it is very, very costly, both in terms of mortality and morbidity. Yes, you don't want someone to come out of a code and it's completely non-functional because we wasted so much time, it was disorganized, and this patient is neurologically completely damaged. So we want to be very careful. We want to make sure that we optimize the patient. Secondly, we all know that the success of a code relies on high quality CPR and defibrillation in a timely manner. So that is something we want to prioritize. And also, some of the things which we've realized is that when we have an organized code with clearly defined roles and responsibility, we do have we have a reduction in the time to medical intervention. The time to medical intervention is defined as a time from when a code is called to when the patient starts receiving, when the patient receives first medication or when the patient receives the first defibrillation. So that time is much reduced in patient once the code is organized. And again, this time has been clearly shown to correlate with morbidity and mortality in patients who go into cardiac arrest. Secondly, we want to improve closed loop communication. And as we know, again, based on the American Heart Association guidelines, this is a very important aspect for a successful code. And we want to improve the effectiveness of a team in a reaction by clearly defining the roles and responsibilities much earlier. So again, we said in order to reduce exposure to PPEs, we want to don PPEs before entering the room or the scene of the code or the cardiac arrest. So donning PPE, again, is something which has been a moving target, and you want to make sure that you're familiar with the CDC guidelines on this. If you're going to be directly taking care of patients, you want to be very familiar with the current PPE guidelines. Again, every code member who is participating in a code must make sure that they wear a face mask and must don the PPE appropriately based on the guidelines and recommendations. And again, I did not put those guidelines here because they kept changing. And then secondly, we want to limit personnel that is in the room during a code. And how do we do this? Again, I will show you what we have. So prior to COVID-19, our code teams were composed of almost 16 people, as you can see in this diagram. This is the patient, and these are different people during the code. You need to have a code leader, you have a recorder, a nurse leader, you have the primary nurse. It's a whole bunch of people. But with COVID-19, we wanted to make sure that we limit the number of people who are in the room. And so inside a room in patients with COVID-19 who are going into cardiac arrest, we want to make sure that you have just the code leader, the recorder, primary nurse, an ICU nurse, because in the United States, you do need certain certifications to be able to administer certain medications. In my hospital, the people who have these certifications are ICU nurses, and so they are required to be in codes and help with administering these medications. And then we have chest compressors, or if you don't have a chest compression device, and if you have a chest compression device, then the chest compressor is eliminated. So this literally brings you to just having 4 or 5 people in the room, as compared to 16 people who we had when there was no code. And then actually the rest of the people can be outside of the room, and their function can be successfully carried out of the room. Secondly, our code card is kept out of the room for reduction of contamination, and there are different strategies which different hospitals have adapted in order to reduce contamination. Some of them are just coming in with a small Ziploc bag with what is needed for a code. But again, the goal here is to reduce cross-contamination, and anything which does not need to be contaminated should not be exposed to contamination. So one of the things which came up only during COVID is the use of mechanical chest compression devices. Before COVID, they were not recommended for inpatient cardiac arrest in the United States. Most of them were recommended to be used during transportation for cardiac arrest out of the hospital. So these mechanical chest compression devices help reduce the number of people who are in the room. They reduce exposure to COVID-19, and they do chest compressions at a rate of 100 to 120, which is the recommendation by the American Heart Association, and a depth of 2.1 to 2.4 centimeters, which is what is recommended by the American Heart Association. And again, as we mentioned earlier, one of the ways to reduce exposure to COVID-19 is to clearly define the roles and responsibilities of each member of a COVID-19 cardiac arrest team, or what we call a cardiac arrest code team. So again, just as I said earlier, we do have very few people now in the room. We have, again, the code leader, the recorder, the primary nurse, and the airway management team. Again, we have the chest compression device, which will substitute the chest compression person. So just about 5 people in the room to the max at most at any given time. And then the rest of the people are staying outside of the room so as to reduce contamination. And our code card, which is this one in black, is also outside of the room. So again, the second goal is the last but not the least thought we need to have is how to make sure that we communicate the COVID-19 status to any new provider. So if someone is going to be part of the COVID team, this person has to know prior to anything that if a code is being called, in our hospital, the codes are called overhead. So you have to know that if a code is being called, this is just by the code being called, you know that it's a patient who has COVID or a patient who does not have COVID. And that should permit you to don PPEs appropriately. And again, you already know your role. Your roles are predefined. In our hospital, we have residents, and our senior residents are usually the ones who run the codes. You have junior residents who do chest compressions and all of that. Everybody knows exactly what role they should play during a code for every single day. And again, some of the ways for you to be able to communicate where the patient is if there is a code in a COVID unit, that is a COVID patient, right? Again, some hospitals, like one of the hospitals which is closer to our hospital, does add a C if the patient coding is a COVID patient. They say code 99C or code blue C. And we do have pagers or phone communications which directly communicate communicate to the code team members that this patient is a COVID patient. So you're done appropriately before arriving the scene. A little bit far away from the scene, you code, and then you don the appropriate PPEs, and then you get into the scene and do what needs to be done. All right, so our second goal, as we said, in managing patients who have COVID-19, is to prioritize oxygenation and ventilation strategies with lower aerosolization risk. And how do we use that? How do we do that? So one of the things you want to really think of is using a HEPA filter, that is a high efficiency particulate air filter, if that is available. And again, this has to happen for all ventilations in order to lower the risk of aerosolization. And again, as we said at the beginning of this presentation, if a patient is deteriorating, you want to intubate the patient early enough. Our patient, as you saw, we got the patient to the ICU, but we didn't make it in time to intubate the patient. If your patient is looking like they are requiring more oxygen, it looks like this patient is going to intubate and they're not responding to the increase of oxygen that you've done, go ahead and intubate the patient so that you do that in a non-emergent situation. And again, that is safer. And how do you do this? You do it with a curved tube if it's possible. And you connect to the patient to a mechanical ventilator as soon as possible. Again, once you have to intubate these patients, this is not the time for learning. This is a time when you want to make sure that the person intubating the patient gets that intubation at first pass. So you use the most experienced intubator in that area, or the most experienced, I believe, the person who you know that will get this intubation as soon as possible. You don't have time to play around and again cause aerosolization. Again, one of the things you want to do is pulse chest compressions when you are intubating. This is different from the American Heart Association guidelines for non-COVID patients. They don't really recommend you pulsing chest compressions during intubation. But for COVID patients, they recommend you do that in order to reduce aerosolization. And then you want to consider using video laryngoscopy if it is available. And again, before you intubate this patient, you want to use a back mask device with a HEPA filter with a very tight seal. So once you if you're using a mask, it has to have a HEPA filter and it has to have a very tight seal. You can consider a non-rebreathing face mask as an alternative if you don't have a back mask device, but you do a non-rebreather only for if you don't have a vent available right away, and you do it only for a short period of time. And if intubation is delayed in any of these patients, you do have to consider obtaining a supraglottic airway. Do not delay. And then again, minimize any closed circuit disconnections in these patients. If a patient is already intubated, you do not disconnect the vent for any reason. Leave that vent connected. You leave patient on a ventilator with a HEPA filter to maintain a very closed circuit and reduce aerosolization. Adjust the ventilation settings to allow asynchronous ventilation, and then consider the following in these patients. You want to make sure that you increase your FiO2 to 100%. You want to change the mode to pressure control ventilation, and you want to limit pressure as needed to generate adequate chest rise. You don't want to cause tacking. You don't want to cause the ventilation, any separation or any discontinuation in the ventilation. Again, if a patient is already intubated, avoid any unplanned extubations, avoid any, again, as we said, hyperventilation or any air trapping. You want to adjust the rate to 10 breaths per minute for adults, and you adjust the PEEP, the positive and expiratory pressure levels to balance the lung volumes and the venous return, and adjust the alarms. You don't want these alarms to be going on continuously and causing fatigue. And when someone really needs to pay attention to those alarms, people are already fatigued and they don't do that. You want to make sure that you set your alarm at the threshold, which again, if they go off, someone should take it seriously. If a patient is in a prone position, no advanced and does not have an advanced airway in place, you have to turn the patient to a supine position, because in patients, it's almost impossible to get an advanced airway in a patient who's in a supine position. But if the patient already has an advanced airway, you want to leave that patient in that position. Do not turn them. Because by you trying to turn the patient, you may disconnect the vent, and just cause aerosolization. Place defibrillator pads in these patients in anterior and posterior positions, and I'll show you an image of that. And you provide CPR with the patient remaining in the prone position with your hands in the position of T7 to T10 vertebral bodies. So you're doing, your hands are on the patient's back, not on the chest, as they should be during CPR. So in the first image you see here, these are patients who are already on a vent and they are in a prone position. These are patients who you do not have to turn. And what you do, you place a pad anteriorly and you place them posteriorly on these patients, and you continue with your chest compressions at the level of T7 to T10. So this is the last point which I want to talk about, is again considering resuscitation appropriateness. It's very important that, again, we as we said, address the goals of care for every single patient. And this is not for patients only, but every healthcare system or institution should have clear policies to guide frontline providers on what to do in situations where a patient with COVID-19 goes into a cardiac arrest. And once these policies have been clearly defined, every single provider should be knowledgeable. If you're going to be a part of the cardiac arrest or the code team, you have to be very knowledgeable. This should be guidelines which are not difficult to find, or which you cannot be part of the code team without them making sure that you have these guidelines. Secondly, you want to take into account patients' risk factors in order to risk factors to estimate the likelihood of survival. If there are some certain patients who maybe, again, the likelihood of survival is extremely low, there is no need for you to go to perform a resuscitation in these patients and expose every single person, knowing that their likelihood of survival is extremely low. And again, the policies that the hospital or the healthcare system have decided need to be clearly communicated to the patient or patient's proxy during the course of care discussion. This is not something that you communicate at the tail. You communicate right at the front end while the patient comes, as soon as the patient gets to the hospital. So one of the things I just want to also quickly go on is the algorithm for the BLS. The only changes again on the algorithm for BLS with regards to patients who have COVID-19 is that, one, you want to make sure that you appropriately don your PPEs, and you want to limit personnel in the room, and we talk about how we could do that. The second thing is, and if it's patients who are, and for ACLS, what do you do? Again, you want to limit personnel, you want to appropriately don your PPEs, but it's very important to consider chest compressions. Okay, you want to make sure that if the patient, you want to consider pausing chest compressions during intubation, and if intubation is delayed, you want to obtain a supraglottic airway. And again, you can do back mask devices with filter and tight seal, and then you want to connect the patient to the vent as soon as possible. And this, again, are the recommendations that are a little bit different. And then one thing now, post arrest, again, you have to consult your infection control for every single hospital to know how to transfer the patient from maybe a non-intensive care unit to the intensive care unit after a cardiac arrest from COVID, assuming the patient survives the cardiac arrest. So in conclusion, we want to make sure that we have the minimum number of code team members and equipment in the patient's room. Secondly, you want to clearly define the roles and responsibility of every code team member prior to any them being part of the code team, so that once they're part of the code team, they can be able to perform their function effectively. Thirdly, you want to use mechanical chest compression devices for inpatient cardiac arrest. That is one of the new aspects that was added to the guidelines. And you want to prioritize oxygenation and ventilation strategies with lower aerosolization risk. And again, consider resuscitation appropriateness in this patient based on their risk factors and their likelihood to survive. And So again, I think all of us as clinicians want to give our patients the best chance of survival without compromising the rescuers. Thank you very much. And I'm open to any questions.
Yes, thank you, Dr. Akwe. And I'd like to open the floor to any questions.